And I'd like to introduce Dr. Clara Berridge. Dr. Berridge is an associate professor in the School of Social Work. Her research focuses on the ethical and policy implications of digital technologies used in elder care. She studies data and information technologies such as remote monitoring systems and social robots, as well as the surveillance incentivized by AI of older adults and care workers. Across projects, she's often thinking about privacy, power, and decision making about technology use, as are many of us. Dr. Berridge recently developed Let's Talk Tech. It's the first tool to help people living with mild dementia participate knowledgeably in decisions about technology use in their care. And I think you can see that she is just the perfect expert to talk to us today about technologies for caregiving and aging in place, risks, and ethical considerations. Welcome, Dr. Berridge.
Thank you, Barb. I'm really delighted to be talking with all of you and to be a part of this important series. And please do, I just want to echo the invitation to ask questions. I'm really looking forward in particular to engaging after my presentation. I left plenty of room so we can have some back and forth and talk more about these issues because there's a lot to talk about. All right, let's advance. Okay, so let's dive in. If you are mystified or perhaps even intimidated by the age tech space, you're not alone. In the past decade, there's been a real discovery of the age tech market, or the market of older adults and caregivers, and that's given rise to a dramatic influx of products. And they've been designed for older adults and caregivers for a range of purposes, but many of them are focused on health and risk monitoring. This slide shows just some examples of many hundreds, and some of these incorporate AI, some don't. As you'll see on the slide, there are things also listed like Nest and Instacart and Blue Apron. So these are obviously not technologies designed specifically, not all of them for older adults. So some are designed specifically for the age tech space and some are not, but are useful there. To get you oriented to the specific types of technologies I study, because technology is a ginormous topic, the technologies I study have a monitoring component. I'm interested in those that create some sticky ethical issues, and I'm going to pull one of those I just circled, listed here, called Care Predict, and show you where monitoring technologies, especially with the use of AI, are headed. The image on my screen is from a video advertising Care Predict to the senior living industry. The product draws data from multiple devices in somebody's apartment and is sold as AI innovation to senior housing like assisted living. Both older adults pictured here are wearing watches with symbols to indicate that watches are transmitting data somewhere. And on that dividing line between the images is the single eye symbol that represents surveillance. And in this video, the voiceover says they use, quote, deep learning algorithms gathering data at every second to observe each elderly person through their daily activities, to identify and chart their individual behavior patterns to spot any significant deviation. The Care Predict video goes on to say that it does this, quote, continuously 24/7, making the whole system as sharp and individually vigilant as no single caregiver, either family-related or professional, could ever manage to be. The background image to the words is also from their video, and it shows these red dots moving around. I played the video, representing people in congregate housing to convey the surveillance of their movements. Like most such products, the marketing claims that privacy remains intact. It anticipates privacy concerns and then claims privacy is addressed, so it's dismissed. These assertions and promises in their marketing that are quite common are also questionable. The selling purpose of these kinds of systems is front and center on this similar product's website. This is a screenshot of one called Casper AI. And this is the benefit they note at the top of their list: staff efficiency, and more directly, enabling one less direct care worker while providing better care, they claim. Casper AI boasts that it provides 30+ actionable analytics to care staff. Of course, surveillance of older adults also often also means surveillance of care workers' movements. So it's important to consider their labor conditions as well. That's just to give you a sense for where some of the technology is and where it's heading. You see echoed the AI ethos that more data is best. there's a strong message that more granular surveillance is better care. It's framed as vigilance that surpasses human caregiver capacity. Now, another consideration of what's at stake, particularly in the senior living industry, is how offering of technology is likely to begin crowd out alternatives. So that for the older adult, that could mean fewer options, which could undermine use that is truly voluntary. Because when an organization adopts a system, they want to use it across units. So increasingly, data collection is going to be marketed as a benefit of living there, right? This senior housing or assisted living or this nursing home. And opting out might mean finding a different place to live. In some regions, there aren't a lot of options. And so this begins to sort of complicate informed consent to this kind of monitoring. Now, you probably haven't heard of the aging and innovation discourse, but you have heard the aging and innovation discourse. It's something I know you're familiar with, and I wish Louis Navin and Alexander Payne had called this discourse the aging and technological innovation discourse, because that's what these scholars are talking about. The aging and innovation discourse is said to have a rhetorical power that legitimizes large investments in technologies for older people, because aging is positioned as an imminent crisis that will affect whole societies. So investing in technological solutions is then positioned as a way to generate benefits on a societal level, on an economic level, on an individual level. And these scholars call this the triple win. Digital technologies, including AI, are sold under the umbrella of resource scarcity. And this "we're all winners" discourse is morally charged, and that can make it difficult to argue with. There's little room in this discourse for things like innovation to help address structural problems that might not also generate profit. Right? There tends to be a strong profit motive baked into this discourse. It's going to be financially beneficial for innovation. Now, the kinds of technologies I study include a range of things from location tracking devices to activity sensors in the home, behavior tracking, sensing, cameras, as well as tabletop companion robots that use AI. And I'm focusing in this presentation on technologies that capture some kind of data about a person, usually in their home, to monitor safety or changes in behaviors. And so these things have a lot of different labels. It can be confusing. I'm talking about direct-to-consumer devices, things that people buy directly. They can be called digital health-related tech, ambient assisted living, smart tech, Internet of Things. Sometimes they're referred to as remote monitoring or passive monitoring. There are some components of smart home technology that I'm interested in, not so much the auto stove shut off or the sensor to prevent the tub from overfilling, or voice activated lights, but I'm interested in the smart home technology that auto locks a door when somebody approaches it, or sensors that detect when and how many times someone is moving past it. So the ones that are more likely to raise some ethical questions. And I'm not going to focus on companion robots in this presentation, except at the end, I'm going to share some findings about how people feel about data collection through virtual companions. The desire to predict and prevent health events through increased monitoring and analysis of behavioral biometrics is driven by health and long-term care cost containment, as you know, and the widespread preference to manage chronic conditions at home. But what I've observed is the ethical research on these technologies 10 to 15 years ago had been really slow to emerge, particularly in the United States. The ethics conversation really hasn't kept pace with the developments in tech. There's a very strong momentum in many countries to rely on technologies in care provision without always fully considering how they could restrict rather than enhance autonomy or privacy or human connection and other needs and values. In fact, negative attitudes that some older people hold towards these technologies stem in part from privacy threats. And that focus on ethics, I would say, is much stronger now in academia, where implicated values are increasingly being articulated. There's more studies where we take seriously what people are saying about their experience with them. But despite the gains that we've made, this lag has contributed to a significant translation gap between the work of taking seriously ethics and values on the ground on the one hand, and the implementation, the design, the policy, and the practice on the other. And with the rapid influx of devices and AI applications, I argue that there's now an overdue need to be attentive to older adults' preferences for control and privacy enabled in technology design. Others have recommended autonomy enabling options, such as control over when a device is collecting data. And they caution that if ambient assisted living technologies are a success at the expense of the individual's privacy, then to what extent is the ambient assisted living really empowering or improving the well-being of older adults? And again, we refer to these technologies as Internet of Things, smart health, smart home, remote monitoring. Terms are in flux. A few years ago, we conducted a survey with an existing online cohort that was created at the Oregon Health and Science University. And the sample is age diverse, but it skews older than 64. So half of the people were over the age of 64. Following research on the control desired by older adults in the context of monitoring technologies, we conceptualized control as a form of ongoing agency in which an individual can decide if and what information is collected about them and with whom it's shared. So our survey participants were first presented with 3 distinct types of data collection and use. We talked about location outside of the home, audio for detection of changes to brain health, which is an emerging area in research especially, and visual with audio telepresence robot, so a video chat on wheels that can be remotely controlled to roll around somebody's house. And after asking them to assess their comfort level with each, we presented some control options to them. We presented 5 options and we asked how important each would be considering the technologies I just mentioned. And I fit 3 of those 5 control options on this slide. They are to be reminded every now and then about what information a technology collects about you, to have your primary support person check in with you now and then about whether you've changed your mind about using a technology, to have the ability to pause a technology in your home when you want privacy. And if shown from left to right, they could select not at all important all the way to extremely important. If you look at the high percentages of people who selected very important or extremely important, it's pretty clear that they care about being able to exercise basic control over technologies that could be used in their care. We also found that their comfort with using those technologies is often, in fact, contingent on control options. But these are not all standard in the design of care technologies. They're not often, you're not often able to hit pause. We also have a study of people living with mild Alzheimer's disease, answering the very similar questions. Albeit these findings are from a very small sample of 29 people, but they were asked if they would want each of these options, which overlaps some with the larger survey. And you'll see that they all tended to desire these options. And note also that in this sample, we have 86% who are sure that they want to be able to pause a device. And in the larger survey, with people who are not living with dementia, 94% thought that would be very or extremely important. So enabling these control and privacy options, even in technologies for use with dementia care, seems to be very important for person-centered care. This includes decision-making about using technologies. People want to know if a technology is being used to monitor them. They want to be asked again in case their feelings change. They want to stop if they're uncomfortable, and they want to be able to pause. So they want to be made aware when they're being monitored. And we know that older adults are not likely to be the party driving adoption decisions about care technologies used with them, whether they're living with dementia or not. And there really aren't tools to help people decide what will or won't work for them or to navigate some of the ethical issues. So people are left not knowing how to navigate those decisions in a way that respects the values held by either the older adult or the person living with dementia. And that is, it has limited the ability of caregivers to be able to make informed person-centered decisions that align with the values of the person living with dementia. Involving somebody to the extent possible in these decisions about how and under what conditions and when technology monitors them has been called an ethical imperative. That idea is rooted in this notion of respect for and recognition of personhood. And of course, different people have different boundaries and different desires for technology use. By relationally embedded, what I mean is someone may say, this daughter, but not that daughter, can access this information about my whereabouts. Or, you know, my daughter and I are extremely close and we tell each other everything. And then as I'm interviewing this person, they'll say, after describing them as sharing everything, the person doesn't approve of their daughter using sensors or a camera in their home to monitor safety, because she actually prefers she has control over what tell each other everything means, and that she be the one to do it. So it turns out that caregivers also benefit from being empowered with knowledge about the person living with dementia's preferences for technology use. It can be a source of stress for caregivers if they're making care decisions by themselves that aren't informed, and that's true of all kinds of care decisions. We know from other research on other kinds of decisions that feeling prepared helps reduce stress. So there's a lot of research indicating that we actually should be helping families navigate these decisions. But there are a lot of reasons why a caregiver may be unlikely to involve their partner in the decision. So number one, caregivers often assume that a person cannot understand the basic functions of a care technology. And here I purposely wrote a person and not person living with dementia, because this statement is also true in older adult child dyads where no one is living with dementia. We did a study of people using Meals on Wheels and their adult children, just as an example. We separately interviewed them. We described a range of technologies and then asked them to tell us in their own words what each technology does. So with the older adult, we achieved 100% comprehension in that way. And of course, that took a lot of testing the descriptions before we did this study. And across the board, their adult children told us things like, Mom would not understand what this technology does. So we actually asked them if they thought that their parent would understand, and nobody thought that their parent would understand, and yet we had achieved 100% comprehension. This is unfortunately consistent with the research that finds that younger adults tend to underestimate the capacities of older adults. As you can imagine, those assumptions about people with mild dementia are even more widespread than an older adult who's not living with dementia. Use of technology without informing the older adult results often when caregivers underestimate their capacity to understand. And second, caregivers underestimate the importance of involving people living with dementia. The stressors of communication decline and losses in autonomy can be compounded for them when they don't have a voice in decisions. But caregivers often underestimate not only their ability, but their desire to participate in care decisions and then leave their preferences unsolicited. So number three, the potential benefits of monitoring technologies can come with potential risks, and those haven't been presented for consumers to understand. These include things like experiences of privacy invasion, loss of control, unnecessary restrictions, and reduced autonomy and even human interaction. Companies that are marketing direct-to-consumer technologies, of course, do not raise or address the risks or the negative aspects experienced by the person with whom the technology is used. In fact, the ethical issues are often actively veiled in consumer-facing products and content. So, for example, it's not uncommon for me to see a device state, "This system surveils your loved one 24/7 with their privacy intact." And I believe it's a task for research to provide accurate and balanced information and to guide families to understand, to weigh, and to negotiate the values, the risks, and the benefits that matter to them. And then finally, it's not an easy conversation. The use of certain digital technologies may contribute to familial stress or conflict due to their surveilling nature. And some caregivers anticipate that they wouldn't be in agreement. We get a lot of, "I would love this technology, but my mom would hate it," kind of comments in interviews. And those caregivers might be right about that. Studies have found differences between older adults and family members with regard to perception of need and comfort with the collection of various levels of data granularity, as well as different ways of balancing risk and benefits. So for example, caregivers are likely to be more focused on safety in general, where an older adult may value safety, but put more weight also on autonomy or feeling free than their caregiver does. In the dyad study I did of Meals on Wheels clients noted a minute ago, who were not living with dementia and their adult children, these dyads often express conflicting views about how and when location tracking technology or in-home sensors or web cameras should be used. Adult children felt that involving their parents in conversations and decisions about whether or not to use these kinds of technologies would be complicated, and most felt that they would involve their parents minimally. And their parents, by contrast, interviewed separately, wanted to be involved in those decisions and made aware of technology used in their care. So even in this case, when older parents are living at home and clearly capable of giving informed consent or refusal, adult children reported that they might judge it easier to use monitoring devices without discussion to avoid potential conflict. Left without tools to help with these conversations, we find evidence that caregivers use the the techniques listed here when they want to use a monitoring device. Persuade, pressure, bypass the older adult, override their preference, issue ultimatums. We hear things like, I told my mom it's this or nursing home, moralize, this is the right thing to do, don't you want to take care of yourself? Concealing use, so hiding it, or avoiding decisions altogether and possibly missing out on using technologies in ways that could be really helpful. So I think the question is, do these techniques set families up for successful use? Does this enable empowered technology use? Is it likely to make people feel cared for and respected? And another important note is that economically marginalized caregivers and older adults may have lower access to the knowledge that's required to participate in informed and empowered decisions about technologies, and they may be less likely to have awareness of the options that are out there. So this digital divide that we often talk about in this case isn't going to be bridged by innovative dementia or elder care tech if these options are not understood by intended users and if we're leaving families to navigate the space alone. Thinking about how the digital divide plays out, I'll briefly touch on some contexts where technology use decisions are not being supported. A few years back, I presented for Washington State's Adult Protective Services because monitoring technologies were being encountered in the field and raising a lot of sticky questions. And I informally surveyed those investigators about their observations and concerns. For those who don't know, APS is the service that investigates reports of abuse, abandonment, neglect, and exploitation of vulnerable adults. And that's a category that includes older adults with conditions that impact cognition or dementia. And these are the technologies in the order of how many APS investigators said they're seeing these in the field when they go into people's homes. I am sure these numbers would be higher today. So web cameras were the most common. 95% had been seeing webcams in the home. Sensors on a door or windows, other sensors detecting motion, indicating where someone is in a home or what they're doing. Some noted location tracking of the individual by another person. And then 12% talked about audio recording without visual. And in APS work, investigators have this added consideration of the role of privacy, right? Because they want their visits to be private. They want to protect vulnerable people in tricky power dynamics. So privacy and confidentiality, which surveillance technologies, if used by an abuser, could undermine. And this was a top concern of theirs, that their visits may not be private. And among other top concerns are the problem of consent over the devices in use. So I don't know what to recommend if somebody lacks capacity to consent, or I don't know if an individual gave consent or was consulted. And moving on to the context of Medicaid home and community-based services. In an interview study with state Medicaid HCBS waiver directors that were serving older adults in 15 states, I wanted to understand how technologies were being used, approved, and overseen. And we found that some states through Medicaid allowed and paid for location tracking and activity monitoring sensors. 1/3 cover cameras without specific consenting procedures. And this study is now dated. It was conducted in 2016, so use is now more widespread in this context. But we learned from these managers that consideration of ethical issues was limited, and that the states were struggling, the case managers were struggling to understand which circumstances warrant use. And this is a representative excerpt from an interview with a waiver manager talking about their beneficiaries. He said there's a consent factor there, and understanding if the person knows they're being monitored, and if their representative is solely safety driven and doesn't include evaluation of dignity at risk. So there are a lot of factors. How informed is the person? The representative here would be a family member who's seeking Medicaid coverage for a monitoring device. So Medicaid managers, care coordinators, and APS frontline workers who are encountering family decisions in the field have difficulty understanding how to navigate them. What is at stake? What's at stake in technology use decisions? Studies have found that practices that develop around monitoring technologies can negatively impact older adults where greater exercise of power over aspects of their lives is authorized. For instance, a recent ethnography I've got cited on this slide of dementia care dyads revealed ways in which using sensors and fall detectors led caregivers in practice to unnecessarily restrict movement and remove some of their privileges. It also led them to reduce their personal visits in the study. Older adults may experience other infringements on self-determination, such as right to risk, and it could mean they're subjected to further scrutiny or monitoring. As my colleague Amanda Lazar points out, the implications can be particularly charged for somebody living with dementia or MCI, with the potential to impact where they are deemed fit to live. And another consideration of what's at stake is how offering of technology is likely to begin to crowd out alternatives for them, as I noted earlier. To take a closer look at some of these risks, a few years ago, we conducted a study with domain experts in the United States and Canada. And these are people in industry, people focused on AI. Many of them were gerontologists who study or develop technology. And we wanted to identify the technologies that they thought would be the most prevalent in the next 5 years for use in dementia home care. So they identified collectively 12 of these 12 technologies. And they range from using an AI virtual agent or socially assistive robot for non-human companionship to recording audio in a person's home to respond to emergencies, to monitor socialization. And we had 4 to 12 risks and benefits for each of the 12 technologies used in home dementia care that they provided. And in order to draw out practical risk mitigation strategies, in a multi-survey process, we pooled those risks that were most common across the technologies, and we asked our experts to tell us how to address those risks. These are the most important risks, the most common risks across technologies inherent in some of these technologies. How do we address them? And I'm going to present these common risks, followed by the ways they suggested to mitigate them. But first, of those 12 technologies they identified as going to be the most prevalent in dementia home care, we asked which are the most likely to require a conversation with the person before use. So that is, what could cause conflict if they were used without permission? What could be experienced as most intrusive? And these are the practices that rose to the top. So recording audio in a person's home, video conferencing that allows a caregiver to turn the camera on and enter the room visually, location tracking inside the home, outside the home, using an AI virtual agent or a socially assistive robot for non-human companionship to ease loneliness, remotely monitoring physiological variables for frequent assessment to predict and manage health risks. And I'll present across 4 slides the aggregated most common risks across all 12 technologies used to support dementia care. Number 1 is privacy threat. Probably unsurprisingly. They can also cause uncomfortable feelings, either from feeling like one isn't free in their own home to do as they please, or feeling that there's no place to hide. Experts talked about feeling infantilized or babysat, or that it can compromise somebody's dignity. In the field, I hear very similar concern over privacy as what these domain experts express. On this slide, this is a son of a Meals on Wheels client who explained to me, and this was in response to our conversation about in-home activity sensors for his mother. There is some kind of privacy that's taken away, and depending on the person, it could affect how they lead their lives or how they feel like they can lead their life. Your life is open and exposed in a way that it wasn't. The more and more one feels one's privacy is being invaded, the more and more degraded some can feel. So he's connecting privacy to dignity and to feeling unrestricted, to do what I want to do. Privacy in this way is not just an intrinsic value. It's not just valuable for privacy's own sake, but it's integral and it's necessary to enjoy other values that we care about, from freedom to autonomy, identity, even trust, the freedom to be nonconformist. I will say, as an aside commentary, that unfortunately, in my view, privacy is studied and written about in gerund technology and aging and technology as a hurdle to get older adults to accept a given technology. So it's often framed as, how do we convince people that they shouldn't be worried about their privacy, rather than how do we design a product with privacy options that takes privacy seriously, and a product that actually addresses privacy threats. So the barrier to adoption is framed as privacy concern instead of privacy threat. Do you see the subtle difference? It's a difference of where the problem is placed. Is it the person's concerns, or is it the invasion of privacy itself, a legitimate concern? McNeil and colleagues have provided a privacy framework outlining functions of privacy that they identified through interviews with older adults. And these functions are self-protection, autonomy, emotional release, control over the extent of information disclosed, and to whom it is disclosed or confiding, social identity, self-concept, and protecting others. I've done qualitative work in which older adults also draw very strong lines between privacy and autonomy, or feeling free, as well as self-concept and control over disclosure. All of these values, I would say, are intertwined with privacy. Back to our common risks. So additional issues are information or alert overload. Caregiver fatigue was cited as likely to make caregivers anxious. Other commonalities across technologies included a false sense of security. And when a caregiver feels that they're getting the monitoring information they need through technology, this could lead to fewer check-ins, to the detriment, and in some cases, the benefit of the older adult. And then experiencing harassing questioning by caregivers, not being given room to depart from routine were commonly cited risks. Older adults changing behavior to conform, and that's something I've actually observed happening in practice in my research. So you see, when one's daily behaviors are no longer private, there are implications for self-determination, and there are disciplining effects of being constantly monitored. People start to conform. And then finally, participants voiced concern that recordings that lead to knowledge of non-adherence or high-risk activities could in turn lead to increased premiums or denial of healthcare coverage. Experts also emphasize security risks as unresolved problems, or this idea of big data collection being needed without much knowledge for where it may end up. And the fact is, with more data are increasingly easy to re-identify, and people do not understand data disclosures and permissions used by companies to use or monetize their data. I'll talk a little bit more about that later. I think those are issues that are top of everyone's mind in general now. Here's the good actionable stuff. So we really want to get to, so how do we mitigate these risks? So these experts collectively identified strategies, and listed here only the high-level categories of risk mitigation strategies, which we outline in detail in this paper. If you're interested, they actually describe what each of these means. And I'm going to zoom in on a couple of those. So intervening during design is important, making specific technical choices, building in choice and control, enabling informed consent, proactively educating users, placing restrictions on data use and ensuring security, and requiring data transparency. So one takeaway from this study is that solutions to protect against various forms of privacy threats need to be multi-pronged at various levels. There's really no catch-all solution here. Clearly, there's a need to design in opportunities for control and privacy-informed products from the get-go, and that would be more responsive to older adults' preferences. A very tiny effort of mine on this front is that I co-teach a class on interface design offered in the UW School of Art History, and Design for undergrads on the importance of designing Internet of Things with control and privacy in mind for older adults, and providing transparent and clear information about what's going to happen with their data. It's very interesting. It's such a privilege to get to talk with undergrad design students about how to meet older adults' privacy and control needs. And once we explain sort of the research and perspectives of a diverse array of older adults on these issues, the undergrads, I find, really get it pretty quickly. And that interdisciplinarity is really important in education. And it's also a blast. I'm not going to dwell here because I don't believe this is not an audience of designers. But this focus is needed because engagement with ethics has been a problem in design. A relatively recent review found that most dementia care technologies have been developed without consideration of any ethical principles, which is striking, right? Given how shot through with ethical issues dementia care is. And it's important that users understand this, I think, so they don't make assumptions about what's been considered. The second category I'll highlight is where I've spent a lot of time working on this level of user education through intervention development. So that means proactively educating users during use decisions and enabling informed, shared decision-making for people living with mild dementia and their care partners. Diving into the specific recommendations under the category of enable informed consent. What does that look like? So domain experts suggested being transparent about potential positive and negative aspects of monitoring, as well as the data flows. Can we help people not just understand what a given technology does, but actually appreciate what it might mean for their daily life? They also suggested establishing informed consent as a process rather than a one-time event so that people could actually revisit their use. And then because it's really hard to fully predict how something is going to be experienced in practice, ideally there are opportunities to try it out and make adjustments. And then we need to provide alternative options because how free is a choice when there aren't alternatives? It's not really a free choice. And then something like advanced directives. This recommendation aligns well with other research that has identified the need to educate families about the technology's risks and benefits in a way that's accessible, clear, meaningful to them, and that includes forward-looking consent processes before dementia might undermine informed preference formation or the ability to express a preference. One way to think about this is as one of the 4 M's, what matters to people. An aspect of understanding goals of care is understanding preferences regarding the extent to which one wants more intensive personal data monitoring outside of the clinic. So we have to address the barriers to comprehension that is required for informed consent. Nearly all the participants emphasized the need for control to be offered to older adults and their families in the use or design of these technologies. This is another of the risk mitigation categories, and here's what built-in choice and control might mean. So ability to pause, allowing individuals to stop using it. This should sound familiar by now. Those are popular control options in the survey findings I shared. And here they're speaking to a clear need for personalized options and ways to actually enable them. So a caregiver who wants to respect somebody's privacy, wants to enable somebody to pause at a moment when they want privacy, that button might not be built in. There may not be an option for that at this point. And then allow individuals to stop or not use, also important to older adults. And this last bullet point is huge. It's not voluntary and not non-coercive if it's the only option offered, or if it's an ultimatum. There may be consent, but that doesn't make it an ethical process when choices are that constrained. So I realized that the need to develop a tool to address this was really striking. And I'll tell you a little bit about the intervention I developed to help meet this need. Let's Talk Tech is what we call it. It's not an acronym. It's not the best name, but at least it's not an acronym. It's a self-administered dyadic intervention that takes about 45 minutes to complete. And its purpose is to facilitate education about various technologies, dyadic communication and preference formation, and then sharing of the person with dementia's preferences for how technology might or might not be used in their care. And it doesn't require a trained professional, but it does require that at least 2 people sit down together using an internet-connected device to complete. It's delivered in the form of a web app, so it's like visiting a website. And it consists of education about 4 general categories of technologies that collect diverse types of data that people might experience differently. So we have location tracking, in-home sensors, cameras, and small companion robots. It then offers a comprehensive assessment of potential benefits and risks of each technology based on findings from multiple studies, and it presents them in a clear way for people to consider. and then guides the dyad through a discussion about how people feel and what technologies the person living with dementia might want and under what conditions they would want them to be used. And the user is a person living with mild stage dementia. And of course, other options are provided within this web app, like PERS, or more walks with family or friends, or a home aid, or a medical alert bracelet, and so on. So we don't only provide the feature technologies, we provide additional options for people to consider and talk about. And the intervention is grounded in this theory of dyadic illness management that was developed by Karen Lyons, who's also been a mentor in this work. This theory posits that care dyads with shared appraisals and more collaborative illness management, like shared decision-making, communication, care planning, are going to have better health outcomes. So the focus is on supporting the health and well-being of both parties in the dyad. About a year or so ago, we completed the pilot study of this with 29 dyads. These were participants enrolled in the University of Washington Alzheimer's Disease Research Center, their clinical core or research registry. They had a diagnosis of Alzheimer's disease in mild stage. All but one of these dyads were spouses. And these are the outcomes that we were hoping to achieve. We wanted care partners to improve their knowledge of the person's preferences. We wanted them to feel more prepared to make decisions. We wanted both groups to understand the technologies better, to be able to understand a technology really supports informed decision-making and preference formation. And then we wanted care partners to perceive that the person living with dementia understands the technology. And we wanted to do that because we know that if they don't perceive that they understand, they're less likely to engage them or take seriously their preferences. We also wanted people to have a greater sense of mutual understanding. I understand their feelings. I feel they understand my feelings about these technologies. And the pilot yielded very positive feasibility and acceptability findings. People appreciated that the information was presented in a balanced way, that it came from, university versus industry. It's research-based. No one's trying to sell them anything. Most people rated the tool as being very helpful and were likely to recommend it to others. We did a lot of work with clinicians who interact with people living with dementia and their families every day to write content in a clear way. So we use short sentences with one idea and not many ideas embedded. We avoided requiring too much abstract thinking. And everyone at the end had a summary of their preferences documented for future reference. So because we had such high completion, everybody was able to have this documented summary. Between pre and post test, we had statistically significant improvements on nearly all of our desired outcomes. There were statistically significant improvements in care partners' feelings of preparedness to make technology decisions and in their demonstrated knowledge of their partner's preferences. So we didn't ask, do you know your partner's preferences better? We asked, what are your partner's preferences for X, Y, and Z? And they improved. So that's what I mean by demonstrated knowledge. There were also statistically significant improvements at post-test and care partners' understanding of each of the featured technologies, and promising improvements in understanding some of the technologies by the participant living with mild AD. Care partners felt far more understood by the person living with dementia, which is a really encouraging finding because the intervention centers the voice of the person living with dementia. We had some concern that we had overcorrected for the fact that they often aren't given space in these conversations, but both these data and the exit interviews showed that care partners felt that they were able to express themselves and felt heard. In fact, even more than the person living with dementia reported. And I do want to highlight too, care partners across the board perceived improved understanding of each of the 4 technologies by the person living with dementia. We interviewed each dyad after, and these are some of the ways they articulated the value of having this facilitated conversation. So participants reported that they may have wanted to talk about these things, but that this provided an opportunity to do so in a clear and, quote, non-threatening way. Care partners described feeling that they may not have known how to ask these questions, and that it gave us the direction to talk about it just out front. One person living with dementia said, I think this could be a good thing to have because it gives you a chance to sort of codify. One of the most common themes that was noted by everyone was that it raised awareness about options that were available to them. So one care partner said, I'm 79, and it's kind of like, whoa, there's a lot of new possibilities that we wouldn't even know existed. So I think it's important to really evaluate it and say, would this be helpful or not, you know? And then their partner said, yes, that's very helpful to know what your options are. And while they were not asked about immediate behavior change, a few dyads offered that they had already taken action 3 weeks after doing this because of completing Let's Talk Tech. So for example, one dyad bought and installed a web camera. Another started using a caregiver app that they had stopped using previously. And then a third started using an ID bracelet, which was one of the options presented. So each of these explained that this dyad intervention had prompted some changes in behavior. Dyads reported that the intervention enabled them to share with others, share with each other their perspectives on values and areas of importance. So this person with dementia said, it gives us an opportunity to look at how do we feel about these technological things and add our input, get to the heart of our core values and feelings about this stuff. I always find it neat how sometimes dyads finish each other's sentences in interviews. Participants described how the intervention prompted negotiation about possible use. Dyads used the intervention to discuss options and iron out feelings and preferences related to use. A person with dementia said it's for clarification. I mean, no two people think exactly the same thing, no matter how long they've been together. And then in another dyad, a care partner said, every single question we discussed, yeah, everyone, and also some feelings, you know, there again, like we talked about, if we couldn't trust you at the house alone for safety reasons, you know what? Person with dementia said, yeah, and we ironed that out. You know, it's been really helpful. Care partners also gain knowledge of what technologies people would find acceptable or not, and it enabled them to consider each other's perspectives. So care partners express feeling a sense of relief and comfort sometimes from knowing when the person living with dementia would be open to technology use. And in turn, some people living with dementia reported feeling relief that technology or other options presented could help reduce burden for their care partner and that they could feel a part of that support. Another theme was desire to share the documented preferences beyond the dyad. So some wanted to share their preferences summary with adult children or medical providers. They mentioned social workers, mental health providers, care workers. One care partner said, it was a great impetus for having that kind of conversation because I always want to make sure that I'm on board with what my spouse wants primarily because he's got 3 kids who are not my kids. And I'm smart enough to realize even as close as we are, when push comes to shove, there could be issues. Families get rather dysfunctional in these situations. And then another person said, this really needs to be a big family issue, not just the spouse. So based on this feedback, we decided to design in a new feature to enable dyads to electronically share the documented preferences for technology use with others via an email link or a QR code. And we're about to survey clinicians about whether or not they'd find that information helpful to have, such as in the EHR. My hope is that we can ease this process so that we can simultaneously engage their wider care networks. So we would have more people who could direct them to specific devices, who could help them with using technologies, because we know there are a lot more barriers to tech use, preferred tech use, that are beyond education and communication processes and decision making. People need help setting it up. They need help. They need to know who to call if something goes wrong, right? And so if we can activate the larger care network, this could help them. Okay, so there were a lot of unknowns going into this. You know, can we effectively describe technologies to people living with mild dementia via words and icons? Could we get them to sit down together to complete a 45-minute intervention on their own? And because the design research on web app development for dementia is really early stage, we weren't even sure that our interface and design and accessibility choices were going to work. But I think most importantly, would people get more stressed out learning about these technologies, right? Or would it provoke conflict just to talk about it? We learned from our pilot participants that they felt that any discomfort was well worth what they gained from completing Let's Talk Tech. And of course, we closely monitored measures like anxiety to make sure we weren't causing harm by asking them to discuss these things, and we weren't. So our findings of feasibility and preliminary efficacy are exciting because they show that comprehension and communication challenges can be overcome. And hopefully this can help open new doors to facilitating shared decision-making and ultimately satisfaction with their choices, which would require a longer study period to evaluate. And I want to give you a sense for how differently these participants with mild AD felt about the technologies the intervention focused on. This table is just the first 16 of the 29 people, their preferences. And each row is a person. And we have 7 technologies on the top. And Y means yes, they wanted the technology, N means no, they didn't, and U means unsure. And so if you look across the rows, this is to show you that people's desire for digital technologies used to monitor them and support their care is not necessarily consistent across devices or purposes. Preferences were very technology specific. No participant desired all of the feature technologies, and only one, the first one here, rejected them across the board. So that supports an understanding that preferences are going to intersect with personal circumstances, needs, values, and also negotiation with families. And in fact, we assessed how people rated values such as privacy, freedom to do as I want, remain living at home, and safety. And we found no association between how important each of those values was to the person and their technology use preferences. This really does, though, check out against previous research with a range of older adults. I've interviewed people who emphasize how important privacy is to them, but then they'll express that they'd be comfortable with activity sensors in their home, but they'll find location tracking outside totally unacceptable, or values and relationships intersect in unexpected ways. For example, the person living alone without a primary support person who describes herself as fiercely independent, who told me, I would love it if someone cared enough to watch my life on a camera. So it's very hard to predict, again, relationally embedded preferences. So we really need personalized, tailored solutions for person-centered use decisions. So that was an example of an intervention to mitigate risks by enabling informed consent and proactively educating people. But the reality is that some of the risks that are posed by these technologies require policy solutions, not interpersonal education and communication tools. That's not the only level that things need to move to achieve these goals listed here, these risk mitigation techniques. You can't have fully informed consent without accurate information about what you're consenting to, and that includes how your data collected through a system is going to be used. So this includes content of privacy policies that companies are not currently required to make comprehensible. So I just want to touch on this issue before closing. So we find that there's a mismatch between what people want in terms of how companies use their data and being informed of that, and what companies are required to do. Another example is health apps developed for people living with dementia. Recent research has shown that despite the fact that they collect personally identifying information, most don't have a privacy policy, and they are sharing or selling data to outside parties. Also, I'll note without regulation, companies are not under obligation to do bias assessments of their algorithm or otherwise assess impact of their technology development on people's lives. So the survey of 825 people that I opened with included a section focused on companion robots or virtual companions. We showed them a couple examples of tabletop voice interactive robots. So these are robots that can talk and listen. They're not Pero, the harp seal. They're not animaloids. They have voice and they're interacting verbally. So we explained their function of holding conversations, the idea that they could mitigate loneliness. We asked them about their comfort level with them, but what I'm going to focus on here is their opinions about data collection by virtual companions. We asked them about desirability of collection of 2 types of data and desirability of sharing it with various entities. Generally speaking, they do not want those data shared with insurance companies or technology companies. They're more comfortable with maybe a spouse, and then after that, perhaps medical provider. So we prompted them to share their thoughts in words. After surveying them about this, they had an open comment box. And then we did content analysis of the more than 300 responses written in. And the most raised issue was that of invasion of privacy perception, that companion robots that are collecting data is excessive monitoring, People expressed concern that the approach would reduce human contact, especially if it were found to be less expensive than providing human care. But on our data protection topic, the issue of data security and third-party use or exploitation of data were also specifically noted by numerous people. This is an example. This person said, overall, I like the idea of an AI companion or device to check in on a family member, particularly to alert medical services and family if an emergency arises. However, I have concern about how that data is being stored and used by third-party companies. Far too often, it's not being stored securely and being sold to third-party companies for data aggregation, which is accurate. Some pointed specifically to dementia as a vulnerability to data misuse. One wrote, would these systems be encrypted? Who would have access to the data? Would it be secured in a robust manner? The opportunity for companies to use this data would enable them to exploit someone with diminished capacities. Another said, I use a lot of technology. I worry about infringement of personal information. Dementia would affect my ability to monitor abuse of information. And then another wrote, my mood is not a piece of data like my temperature or blood pressure. Yet people tend to accept as information things which are stated with authority. There is huge opportunity for intrusion into privacy and for action taken in reliance on mechanical intelligence against the wishes of the patient. And you see this person is also anticipating detrimental impacts for agency from automation bias, or this tendency. Automation bias refers to a tendency of people to assume that data or something that comes from a computer is objective, fair, authoritative, and correct, even if there's evidence to suggest otherwise. People emphasized need for policy in addition to good practices, and many stated that their desire for any of these technologies is dependent on their ability to control them. I think interestingly, all of the participants who self-identified as current or former tech industry workers expressed aversion and strong concerns about data security and privacy. Unlike the European Union's GDPR and in some US states and cities, the US at the federal level doesn't have comprehensive law that protects people's data privacy and rights. And this is quite absurd given what we know about widespread practices with people's data. We don't have consumer data privacy protections, really. We don't have control of our information. We don't have transparency. There is no federal requirement that privacy policy statements be accessible. And those direct-to-consumer devices, like the technologies I've mentioned, are not regulated. And I think the survey participants who were speaking to those concerns were absolutely right. You often see in the news examples of misuse of health-related data or health data. And if you think about products like mental health apps or medication reminder apps, these are sensitive data that the apps have, and one can infer someone's diagnosis from their medication, for example. But oftentimes the consumer is not informed about this or isn't aware that that's a possibility. So because I think this is an issue that's terribly important, I'd like to point you to some further reading in case anybody's interested. Dr. Anita Ho is a bioethicist at UCSF, and she does an amazing job in her book out last year that describes the policy gaps, particularly around direct-to-consumer and wellness technologies that are often targeted to older adults, but it's really a book about relational autonomy and ethics. It's a fantastic book. I think all graduate students in health sciences should be assigned this book. Highly, highly recommend it. So to wrap up, these are some of the key issues on the slide that are worth grappling with, I think. More recently, I've added this last one because it's evident that another key question needs to be, how do we enable, perhaps through opportunities for public participation, to ensure that the unique interests of older adults are represented in AI governance, especially regarding data-intensive technologies used for care purposes. How do we support decision-making in which people's preferences and values are considered? How do we ensure people have opportunities, when possible, to manage their boundaries? And how should information and data technologies be presented to enable meaningful engagement? So Let's Talk Tech was developed with the support of funding from the National Institute on Aging, and an unmatched team of programmers and collaborators and wonderful doctoral research assistants, as well as clinician consultants who are too many to be listed here. But I want to especially acknowledge Dr. Bill Lober in the School of Nursing's team of staff at the Clinical Informatics Research Group, who I've relied on to build the Let's Talk Tech into an online tool, which we had to do because of COVID. And I want to invite you to contact me if you have any questions or experiences you want to share beyond the Q&A time. And now I welcome questions and look forward to talking.
Thank you so much. You like have made me think about issues that hadn't really occurred to me, but I can see are so important. We do have a question asking, how do you handle situations where the individual is clearly impaired
Yeah.
and refuses options that are beneficial?
So I think that's really tricky. And where I focused is on trying to get people's preferences and a sense for what would matter to people before they lose their capacity to express that. I think that, unfortunately, it's evident that, people are going to need to be required to do things they don't want to do at a certain stage, if it's to support their safety or their health, right? So when it comes to these kinds of technologies, I think there are a lot of considerations. So one is, what would the person want? Sometimes a caregiver is left to just weigh the costs and benefits there. I think important questions would be, is this tool, is whatever we're planning to do, does it have any negative consequences for the person? Such as, will it impact if contact is important, and we know that physical contact is often quite important to people living with dementia. Is there a chance that this will lead to less of that? Is it an issue where they're feeling their autonomy is being undermined? Are there ways we can enhance those feelings in other ways? Having conversations with people can be helpful. It really, though, depends on the person and where they're at and what they're capable of. So it's hard. It's a really hard question to answer generally. But it is why I think having the conversations earlier could be really helpful, because I think even if, a situation changes, and we're not asking people, if this happens, then what would you want? That's way too abstract. Even people without dementia can't answer those questions often, although we try to ask them to. So I think it still provides the care partner with some context and sense of what matters, what are the concerns about doing this, and could we overcome some of those, or could we adjust? So I think the conversation early is really helpful.
So you've talked about the care partner, and I often think about that as being someone in the home. But is, are these technologies and these issues of getting consent and reassessing preferences, do they occur when care partners or family members don't live in the home? Um, and the
So
person,
when somebody's living alone and it's
yeah.
distal caregiving, yeah. So we intend for this conversation tool to support people in those situations too. Absolutely. In our initial study, because we got a lot of spouses, they were living together. But we hope to be able to pilot it with more people who are not living together, because those decisions are equally important. And I think that it could potentially, there's a lot of, transnational caregiving happening. We're about to do an efficacy, a randomized controlled trial with many more dyads on the East Coast of Let's Talk Tech. And I'm eager to find out if it's efficacious and then translate this, because there just aren't enough interventions available to people, especially in early stages of dementia, and especially to dyads. And we know that dyadic interventions can sometimes be extremely impactful compared to like an intervention for a single person.
Mhm. Have you, so it's interesting you bring up transnational, because that was another question I had. And that is, have you had to deal at all with state specific differences in what's appropriate or
Mhm.
what needs to be dealt with before these technologies are brought into the home?
No, so right now, the direct-to-consumer devices are really not regulated. And so I'm not seeing differences with regard to states are trying to regulate data sharing, et cetera. There are states that have different laws related to data privacy protections, California and Illinois. There are a number that they're developing them in part because the federal government will not act on it, and we're quite desperate for some privacy protections, data privacy protections. I'm not seeing it play out yet in the field. And I also think when you have those laws, you really also then have to educate people about how to act on them. The people I'm talking to are not reading the privacy statements, if there are any, and so they may not even be aware of what's happening with their data. So it's not sort of at hitting that level. What would be nice is if overburdened and tired and exhausted caregivers don't have to read those, and that if we had protections in the first place and reasonable protections, and they could just assume, that they would be alerted to data use, or they would have options if the companies wanted to use or monetize their data. That would be ideal. We really need regulation on this.
And is your work involving mainly the technology in the home, or like how is that different from perhaps a skilled care facility or some sort of congregate living facility that is putting technology into rooms and
Right.
maybe not interacting as much and relying on the technology to do the monitoring and services?
Right. Yes, so that's a huge issue. One of the reasons I did that home and community-based services study with Medicaid waiver managers is because the folks at CMS were seeing, this is way back in, I think I was talking to them in 2014, they were seeing that some of the residential services the agencies were wanting to put a camera in the bedroom and remove the staff from the home completely. And these were in situations where people required 24 supervision. That's a stipulation of services. And so they had concerns obviously about that's not a safety issue, but also it raises questions about, if you have the person, then you have the care workers now watching multiple screens. What does that mean for job quality, for relationships, for interactions? I mean, is this a way to sort of allow for understaffing? Is that really the direction we want to go? Certainly, as you saw in some of my initial slides around some of the new AI devices, they're directly marketing to senior living, and in this way, you can accommodate fewer staff. So obviously, that means there's going to be a little bit less interaction, like human interaction, if you have less staff. Yeah, and I think that raises ethical questions as well.
So I don't have other questions from other people, but other questions are still occurring to me if you don't mind.
Sure.
I'm wondering what you have found in your work, or what is maybe being described in the literature about cultural or racial ethnic considerations with
Mhm.
these technologies. I could see there being concerns about who's doing the monitoring, but also maybe cultural or racial ethnic differences in the options that might be preferred.
That's a really good question. If there's anybody who's a student here or a researcher looking for a project, this is an area that I think we really need a lot more work and focus, because technologies are not neutral. There are values embedded. Um, People, and values are often cultural commitments. And so it does matter often. We don't yet know enough about how different people, in terms of economic status or racial ethnic background or immigration status, feel differently about collection of their data like this. What we did with the Let's Talk Tech tool is it was based on a study it was motivated by a study I had done with HUD Senior Housing, and working with people who had immigrated from 10 different countries, and seeing the social workers in these sites explain, and these were bicultural social workers who were also immigrants, explain the differences they were seeing by cultural groups. And it's qualitative work, so I'm not making any generalizations, but things arose, and they have to do with cultural, they have to do with expectation around what role the government, or what should they be entitled to with regard to care and support. It has to do with contexts like intergenerational family cultural conflict. We found a lot of people feeling, especially people who had moved from Korea or China, who expected to live with their adult children, were put in a senior housing facility, and they felt a lot of sadness around that, and that impacted their experience with monitoring technology. They had issues with it based on that. So context is so important, and context includes a lot of different considerations, and we need more research there for sure. I think there's probably obviously some extra considerations around privacy, maybe for some immigrant older adults who maybe they may be documented, but maybe some of their family members are not. They may have concerns about safety. You have untrustworthy healthcare systems experienced by racially minoritized older adults. They may have more concerns or less concerns. They may feel more seen or hyper scrutinized. We need to do more research on that.
Mm-hmm. Jamie is asking for caregivers who want to talk about technology tools to help their family members. Can you share maybe some ideas about how to get that conversation started?
Yeah, so I'm sorry. I know I presented an intervention that's not yet, I can't give to you yet. We need to show that it's show efficacy first, and before we can get it out there. And I know that's a bit tricky. So, but what I can say from what we've learned, ways to get the conversation started. I think expressing to the person initially, it's really important to get your opinion on this, like get their attention, right? We really want to, it's important that this is a shared decision. So get people on board that this can be a dialogue, that you're going to take the person seriously. And then in describing the technology, so if one of those barriers was, will somebody comprehend it? Don't go in the weeds. You don't need to try to explain how something is tracking your location or whatever it is. The function is what matters. So what is it? What information is it getting about the person that you wouldn't otherwise have? That's what matters. Who's getting it, right? And they may be interested in, so how often is the data collected? But wait until people ask questions to get really specific, because it could get confusing. I think that makes it clear. I think don't try to cover up potential concerns. Don't try to sell something as it's all great, it's all good for you, when it's for your peace of mind as a caregiver. And actually, you are going to be able to see, for example, you're going to tell somebody's visiting, and you might be inclined to ask about that person, or there may be a privacy invasion, or address people's concerns when they ask them about, what if I have somebody over? Are you going to hear audio? Like what? These are all legitimate. So I would say take these issues seriously. Don't try to rush past them. So it's important that people feel, especially if you have mild dementia, people are, as I mentioned, pretty sensitive to their eventual loss of autonomy and control. And so this can be a way to provide that, right?
Mm-hmm. So if the family decides to install the camera, do we as clinicians need to educate them about the information? Do we have a responsibility? Is a great question.
Yeah.
To educate them about the information and how it may be transmitted, a concern for privacy, if they're just hearing from the family that they want to do something like that.
Oh my goodness, that is such a good question. So this is the question. I mean, to me, this is the question. Who's responsible? Who is responsible for transparency? For with the digital divide, especially, people have different access to knowledge and information about this, and that's not fair. I think we would agree. The tech companies are not being held responsible for communicating about this. So is it healthcare that becomes responsible when they're encountering these technologies? They're not integrating these technologies that are used in the home into clinical information as much as they will be in the near future. But especially when that starts to occur, when now the provider is actually getting some of this information, I would say that to the extent that the provider understands it and is capable of explaining it, I think it's a great idea to do that. The problem is there's not a good source for people. There's not, I don't know the extent to which AARP educates people about this issue specifically. But I think there needs to be. I think that this is a digital divide. This is an algorithmic awareness problem. And there have been people calling for transparency and public participation in decisions about policy related to AI specifically. And this is one of those spaces where I think that's needed. But I think there needs to be some kind of big education movement. There needs to be some entity responsible for that, because you also can't expect providers to understand this without education. And that's going to be evolving education, because things are evolving
Always.
quickly.
Well, and that brings up a point because you mentioned your study with APS workers. And I think we have a couple of people sometimes from APS that are attending
Great.
these lectures. And I'm wondering if there's a point at which family members providing or installing technology becomes an APS concern.
Right. Yes. So this is an area I just talked to somebody who does a lot of work on abuse and is just turning to elder abuse and is also thinking about technology, because and I have done a little earlier work on cameras in nursing homes. So the use by families of cameras to deter or detect abuse by staff. And we make the point in that work that while staff get all of the news media coverage around abuse, more often than not, it's the family members who are perpetrators of elder abuse, and it's often spouse or an adult child. And so in what ways, and we know that like in intimate partner violence, we know that people use technology and surveillance in abusive ways. And so there is certainly the potential for that. And I think some of those APS workers were expressing in that brief survey, I didn't get to follow up with a lot of interviews, but they were expressing that concern that somebody is surveilling this person. When you have information about somebody, you have the potential to control, right? Information is power. And so I think it's something we need to be more alert to. I think it'll grow the technologies are more ubiquitous, and I think it'll become an issue that we're talking about more often.
But it is interesting because we don't talk about it that much in our basic education programs for health professionals. But the question is posed there about ethically, where does the clinician stand? What are their responsibilities? Even at least to say, have you considered, or what are your concerns about this technology that's being used if you hear about it? But you're right, we don't have the background to really know
Right.
technology at this point.
Yeah, exactly. And in my space of social work, our school is developing a class on AI, but we're behind, in terms of education. Our EPAS, our education standards, the way we talk about technology is not current yet. So we have a lot of work to do across different provider spaces and education.
Well, this has been a very thoughtful and thought-provoking talk. I'm going to continue to think about it. I put your email in the chat so that if people have additional questions, they can pose them. Here's a question from Margaret asking, what percentage of assisted living considering using AI versus staff? Do you have any sense of that?
I don't. That would require a survey. And I don't have that. We don't know. Yeah, I do know that, it raises issues. It raises issues around because oftentimes when you're surveilling individuals in a living environment, the staff are also surveilled. And so I have some colleagues who study nursing home workers' feelings about the technology, management feeling about the technology, and family members when people have dementia and are not able to interview. And they have very diverse interests, I'll just say, understandably, and different understandings of the purpose of the technology. And oftentimes the management is very interested in monitoring, surveilling staff And that raises a lot of issues. I've written about that in the case of cameras specifically,
Yeah.
but I think it's an ongoing
Well, I
issue
can
in
see
terms of,
it being I think about law enforcement wearing body cams,
right.
and I could see it being a legal issue for some folks as well.
Yeah, and it's such a high litigation space, nursing homes especially. Um,
Yeah.
so yeah, and you have to think too about who are the staff. They're
Hmm.
most often they're BIPOC women,
Hmm.
and most often managers are white, and so there's a dynamic there. Uh, are people being assumed to have some kind of criminality or to not be trusted, to have a appropriate relationship with people? Is this the best way to enable accountability? Because clearly families need accountability in those spaces. But is this a Band-Aid, or can we do better by people? That's my question.
Well, and Margaret is saying that she was actually thinking more about, uh, um, you know, a services remedy as opposed to surveilling staff. It's the issue that there already is such a low staff to resident ratio, and so
Yeah.
is technology a solution to that? For example, in assisted living, but it does raise a bunch of issues.
Yeah. It's seen as a potential solution. I mean, when I first started studying this, the the line was, don't worry, this will not reduce staffing or human interaction, because obviously that would have been an ethical problem. Increasingly, it's more overt. This is going to enable less FTE. So I think it's interesting to see how we've become a bit inured to that. Also, the intensity of the problem probably has increased, especially with COVID.
Mm-hmm.
And there isn't this political will to direct a lot more resources to solving this shortage, right? So
Yeah, I think about the fact, I think it was announced a couple of days ago that the um, Biden administration has just released new guidelines that they want skilled nursing facilities, I think it is, to follow in terms of increasing staff to patient ratios, and they're already
right,
struggling.
unfunded mandate. Yeah.
And Margaret is saying her clients already feel isolated in assisted living, and so
Mhm.
worrying that this could increase the isolation, sense of isolation for people living in assisted living.
Yeah, and the issue of companion robots is also raised as we're going to solve isolation by giving people AI to talk to, and um, you know, we'll see. But in my survey with people, generally people across ages, so all the way, we had people, I think the youngest person was 21 all the way to 80 something, I forget. They didn't think that it would help them feel less lonely if they were lonely. And so
Interesting.
yeah.
Interesting. Well, thank you so much, Dr. Berridge. This has just been helpful, and it's an area, as I mentioned to you, we really haven't delved into in the Jerry series before, and so really appreciate it. Thanks everyone for attending, and I will see you next week.
Thank you.
Thank you.